All right, George Kovac here. I'm going to talk about the dangerous airway again. Consider this an update. I recently gave a version of this talk remotely in Turkey. I have no disclosures other than to say that looking after a critically ill patient, somebody who requires an airway, does cause my heart rate to go up. I have no conflicts to declare. So this is an updated version of the dangerous airway with an emergency medicine focus. This is where I currently live on the internet at CovasGJ, at least for the next little while on Twitter. aimairway.ca is our website. There's lots of educational material. I've been neglecting it of recent, and I promise to update that. And look out for a new site in the future, iresuscitate.ca. This is where I live in Halifax, Nova Scotia, and it's an important place for me to tell you a little bit about. First of all, it's probably one of the safest places in the world from a COVID-19 perspective, and that's thanks to the great public health measures that are in place and the fact that our population follows them closely. It's also an important place from an airway perspective. Historically, we've had a tremendous, close relationship between anesthesia and emergency medicine, and this dates back 20 plus years, and I've benefited from that relationship over this time. So the dangerous airway, it's a subject and a name, as I said, I've talked about in the past, and you're going to see how I frame this. But the first time I had a shared conversation about this subject was back at the Society for Airway Management meeting in Atlanta, and we're at an Italian restaurant, and across from me I had the great pleasure of sitting down and chatting in detail with John Sackles and Jared Mosier, and we talked about the dangerous airway from our perspective, slightly different perspective, but same principles, and I'll refresh that perspective as we move along. This is actually a cartoonized picture of a patient in our department undergoing a COVID-19 protected airway. And I think all of us appreciate the fact that there's new complexity here and that the dangerous airway takes on a new meaning with this global pandemic that we all face. So you will hear me and talk about that context as we progress. I want to go back, and I've said this before, into a day when you finish your rotating internship and then you were licensed to practice. And I finished my internship on a Wednesday, and on that Monday I had a full practice in a small town in Cape Breton. And that evening I was working in the emergency department for the first time after doing a 1-month rotation in emergency medicine. And I thought I, knew my stuff and was pretty overconfident I would stay. And on that evening, on that first evening, reality struck quite literally, and there was a train versus car crash. And I'm not going to get into the details, but there were two patients that arrived simultaneously. One, unfortunately, didn't survive. The second one did. Despite my incompetence, I would say, at the time. And I don't remember intubating this patient in terms of the details, but I did. And I remember traveling to the regional hospital in the back of the ambulance with the patient saying, I didn't want to feel this way again. I didn't want to feel that fear that I faced when that patient arrived, and them having injuries and illness that I didn't feel comfortable in taking care of. And that was really a driving force for me ultimately to pursue a career in emergency medicine, and specifically focus on procedural skill learning and ultimately airway management. So let's pretend that this was the case that I was faced with. And I think all of us can appreciate, and I would have been using a direct laryngoscope, that what you can see here, that little pink, what you see in the patient's mouth is really a grade 2B view, in which you can see epiglottis and you can see the posterior cartilages, but that's about it. And I think all of us would recognize that this is a difficult airway, at least defined by laryngoscopy. And there might have been other anatomical issues that were going on. In this case, again, the patient's C-spine would have been immobilized. And physiologically, the patient was sick, was critically ill. And this also represents a difficult scenario. But perhaps for me at that time, and for others, is that no matter what you do, you're not intubating necessarily critically ill patients every day, regardless of what your discipline is. And that creates obviously a contextual scenario which we have to manage, just like all the other factors that I've already mentioned. What happens in our department now in a tertiary center is that there's a large gallery that always gathers, whether it's part of the trauma team or whatever, when there's a big case going on, and that creates another type of a socio-evaluative stress that's not necessarily very helpful. And then again, there's somebody whose job it is to count the saturations as they continue to fall, right, during this. And this is a specific task that somebody feels necessary that again isn't particularly helpful. Now, as I said, whether it's a direct view or a view on the screen, we all appreciate that that this would be considered a difficult laryngoscopy that is manageable. And ultimately, getting the tube, there are all kinds of factors that influence outcome. And it's important that we pay attention to these details, and this will again become more clear as I progress through this talk. Now, the difficult airway, we all know, surrounds primarily these factors. So difficult laryngoscopy, difficult intubation, difficult mask ventilation, difficult supraglottic airway ventilation, and ultimately difficult front of neck airway or cricothyrotomy, whatever term you choose to use. And there are plenty of algorithms that are around the world that are meant and designed to help us manage or take us through cases that are difficult. And there are guidelines that are aligned mostly with countries and with what language you speak and what culture you live in. And they're incredibly important. And whether they're critical care guidelines or anesthesia guidelines, they remain important documents to this day. Of note, there are no guidelines for emergency medicine airway management, and the guidelines that are most relevant are the guidelines for management tracheal intubation in critically ill patients, a DAS document, Difficult Airway Society publication, and it's an important document that was published a few years ago. Now, in the context of COVID-19, this was an interesting paper in which they looked at the various existing guidelines and looked at the many now COVID-19 airway guidelines, and there are clearly gaps. So we can't just take what we were using before and apply it to performing COVID-19 protected airway, as we all know. And what's important is that we address these gaps. And this contributes to the difficulty and dangerous airway that I'm going to talk about. A little plug for the Project for Universal Management of Airways. This is part one, just the concept and methods publication. And the intention of this project, which has been ongoing for the past 4 years, is to take all the goodness, if you will, using a non-word, from all of the existing guidelines and try to bring them together as a guideline without borders and a guideline without discipline that's helpful to all readers. And we've been meeting every second Saturday, every second Saturday evening for me, and it's been a tremendous experience sharing this path with these people on this screen. But let's get back to the emergency patient and the difficult airway. So why are we trying to look at this? What are we using as part of our decision making of whether we try to proceed with an awake approach versus an RSI? And historically, we look at the patient's native anatomy, what they were born with, and their acquired pathology. And in looking at that, we'll make a decision, not necessarily a quantitative decision, but a qualitative decision of whether we think it's safe to proceed with an RSI or we should go to an awake approach. So again, there's reasonable literature describing the difficult airway, and we put all this together. We mix it up in our head, and we come out with hopefully a decision that allows us to proceed safely for this patient. Now, I'm gonna take the example of the Cormack-Lehane grading for laryngoscopy that most of us are familiar with, at least this version, grade 1, 2, 3, and 4. Grade 1 with being a full view of the chords and represents clearly an easy airway, and the grade 4 view in which you do not see any part of the glottic inlet nor the epiglottis would be an extremely difficult airway. Now, Tim Cook came up with this practical classification a number of years ago, which I think is still a very important, different way to look at it in a bit more detail. And he broke it down into grade 1 to 4, but the 2s and the 3s are subsequently broken up to a 2A, in which you partially see the chords, and a 2B, in which you really are just seeing the posterior cartilages. And then again, the 3A, which is 3s are both epiglottis only views, but very, very different beasts, right? So a 3A view with the epiglottis is deflected up towards you is usually manageable. A 3B view with the epiglottis deflected or posteriorly is a very challenging view, and more closely probably resembles a grade 4 view. The question that arises is, whether this is easy or difficult based on the skill set you have. But the terminology that Dr. Cook used was that grade 1s and 2As are easy, grade 2Bs and 3As are restricted, and 3Bs and 4s are difficult. And just using a slightly different terminology, I think we all agree that grade 1s and 2As are easy, and that grade 2Bs and 3As are challenging, but should be manageable, particularly if you have an adjunct such as a bougie. And 3Bs and 4s are, oh my goodness, they are going to cause you trouble. Very challenging, very difficult airways. The question is, are they optimized views? In other words, is there an iatrogenic component to this? In other words, the reason why you have a 2B view is that you're lifting with your laryngoscope prematurely, and you're not engaging the hyoepiglottic ligament. And there is the reason why you have a 3B view is that you're too far with your laryngoscope, and you're deflecting it posteriorly. And I've talked about this before, but to do proper laryngoscopy, it is really a fine motor skill, and it's a game of millimeters. And when you have a tense forearm trying to do this, you can't move with fine motor skills. And often these views are, the component of these views might be iatrogenic, in other words, related to your fine motor skills that are hard to execute in the situation that you're faced with. So I've talked about EVLI in the past in terms of optimization of laryngoscopy and intubation. I'm going to go over this briefly. Epiglottoscopy is a term that others have talked about, Rich Leviton's term. And again, what it means is that you go in specifically, watching the blade tip disappear as you search for your friend, the epiglottis, not going in immediately to search for the glottic inlet. And once you know where the epiglottis is, then you know where all of the relative additional anatomy is. Valleculoscopy is a term that I've used, and I know there's some people that aren't fans of this, but it's based on an anatomical approach. Again, not necessarily that you're going to go in and view the vallecula, although if you do epiglottoscopy as part of video laryngoscopy, you will view the vallecula. And what we have to try to remember is specifically when we're doing Macintosh laryngoscopy, you want to engage that hyoepiglottic ligament, and that really lives under something you can see, which is the median glossoepiglottic fold. So here, you see the median glossoepiglottic fold, and any premature lift here will not move the epiglottis out of the way, right? Because as we said, we have to go down and engage that hyoepiglottic ligament that lives under that fold. So this is another anatomical approach. Again, if you lift prematurely, you're not going to move secondarily that epiglottis out of the way to get a good visual of the glottic inlet. So valleculoscopy, what we're talking about here is, yes, you can visualize it, but if you can see the median glossoepiglottic fold, that really means that you're probably too far away and you need to engage it further. So again, this is what happens when you just go down a couple millimeters and engage that hyoepiglottic ligament. Voila, the epiglottis moves out of the way and you've got a nice view of the chords. So this just takes it through the entire sequence where you'll see a premature lift happen here, right? And this could be part of your epiglottoscopy, where it really doesn't move anything out of the way until you get your blade tip in the base of the vallecula. So it is a game of millimeters, and when you've got a lot of force, it's hard to move and use that fine motor control. So if you lift too early, you might not get the view that you need. If you lift too late, you can actually potentially have an iatrogenic grade 3B view, which I've talked about, and that's because you could be displacing the epiglottis posteriorly. Ultimately, certainly with Macintosh laryngoscopy, a better view correlates with easier delivery in terms of intubation. So epiglottoscopy, valleculoscopy, laryngoscopy, and intubation are closely linked, and we've talked about this before, is 3 things with 2 hands and first attempt. Some people have been critical about, well, what happens when I'm using that other hand? Well, sometimes I need 4 hands to help me. I'm obviously not going to leave those hands there. I'm going to either put towels underneath it or use somebody else's hands or whatever is required. So the first part of this is doing a head lift, and this can be an additional head lift beyond the sniffing position, may increase and improve your view, and if it does, you place some towels, additional towels under there to facilitate this. But this is just really a video that shows you the importance of positioning that people often forget. And ELM, external laryngeal manipulation, you do it first yourself, and if that's of benefit, then somebody else will do it with their hands. But again, this is part of your using 2 hands to facilitate your laryngoscopy, and then have a bougie available to you on first attempt when you're doing Macintosh laryngoscopy, right? You see a premeditated left or quarter turn to the left or counterclockwise before your tube impacts potentially on the right-sided structure. So all these 3 things can happen using your 2 hands on the first attempt, and if you train to do that, that will all happen in less than 30 seconds. Now, again, most of that pertain to a Macintosh laryngoscopy and intubation. With hyperangulated VEL, valleculoscopy is also a term that I think is relevant. We believe that your blade tip is better placed in the vallecula as opposed to picking up the epiglottis, which often happens. So we should be doing epiglottoscopy, as we talked about before. What happens is if you're too close to the glottic inlet, you're more likely to you're going to be causing over-rotation of the blade, which is going to deflect the glottis superiorly or anteriorly, and you're going to be looking up at the anterior tracheal wall, as opposed to being in the vallecula and derotating your blade so that the distal third of it is in line with the trachea. It's going to make tube delivery a lot easier. So as you see here, this is going in too deep. You don't see the epiglottis. You're not in the vallecula, and you're looking up at the anterior tracheal wall. And you need quite a curve on your tube, and that tube is often going to hit anterior structures. It's getting actually caught here on the cricoid ring. That's that bump that first bump that you're seeing, as opposed to if you're in the in the vallecula. With your blade, and you have the distal third of your blade in line with the long axis of the trachea, you require less of a curve on your endotracheal tube, and tube delivery should be a lot easier. So as I said, Rich Levitan used the term epiglottoscopy. But this is an editorial. This was an unsolicited editorial that Rich and I wrote back in early 2020. And what it was is a statement that we have a lot of discussion about devices, and that one device is better than another. And I don't disagree with the value of various devices out there, but the device itself is never going to rescue your patient, really. And we need to, I believe, move away from this debate about types of laryngoscopy and focus in on how do we optimize emergency airway management? How do we optimize pre-oxygenation or peri-intubation oxygenation? How do we optimize doing good direct type Macintosh video laryngoscopy? How do we optimize hyperangulated video laryngoscopy? And I think that we'll save a lot more lives focusing in on this, as opposed to the debate of what type of device we're using. All right, so again, where are we? We talked about difficult anatomy or pathology, again, trying to help us make a decision as to how we proceed. And really, to keep it simple, there are two big picture choices. There's an awake approach versus a rapid sequence intubation. So we consider their native anatomy, their acquired pathology, and look at the various factors that we've already talked about. But the other kid on the block, if you will, as I've already referred to, that's under the umbrella of the difficult airway is difficult physiology. And obviously, this should influence how we approach the patient, and I'll talk about that in a little bit more detail. And this concept's been around for a long time. In fact, the first time I met Scott Weingart or saw him on stage was him giving a talk on the laryngoscope as a murder weapon. Actually, this was during a course that I was teaching along with Scott at Rich Levitan's Airway course in New York. Over recent years, there's been a lot more literature to support this concept, and this is an important, I think, first paper review article by Jared Mosier and John Sackles et al., and describing the physiologically difficult airway. And more recently, there's been more literature on this. I'm going to refer to this paper that Jared published not too long ago in British Journal of Anesthesia, and the most recent document was published in Anesthesia and Analgesia, was these recommendations that came out of the Society for Airway Management on the physiologically difficult airway. And even though there's a pretty broad definition, this really encompasses the major types of physiologic difficulty that we're talking about. By far the most common is the apnea intolerant patient, the patient in shock, the patient with RV strain, or the patient is acidotic. And as you can appreciate, sometimes this is happening all in one patient. And this should, I think, influence our decision making. So this was I had the great pleasure of listening and watching Jared present this live in Amsterdam at the World Airway Management meeting in November of last year. And I think this is a great description and a visual here in terms of risk of desaturation and how this risk of desaturation might influence our approach, right? So those patients that are low to moderate risk, and in present day context, it might mean, for example, that you have to manage a patient's airway because of airway protection, and that they don't have any sort of primary respiratory illness, and there might be just a suspected or an unknown COVID status with community spread. Pre-COVID, again, our approach would be to flush rate, denitrogenate them with cranking up our oxygen above 15 liters. And again, employing all the other things that we talk about here, and performing a rapid sequence intubation and mass ventilating them as required. So this is sort of an approach that you can do primarily passively. The patient who has, for example, shunt physiology, are at moderate to high risk for desaturation during airway management. And this is a patient population where their pre-oxygenation might be done actively using BiPAP, and again actively ventilating them as required. And then the last group that are very high risk, and these are the patients that we would classify as apnea intolerant and might have other factors that are at play. This is probably the group that I'm most commonly, and others are most commonly performing an awake intubation on. And and this represents not an insignificant number of patients who are critically ill. And this is a whole other topic for discussion in how you do this in somebody who's critically ill. But this is a nice way of sort of framing this. And I'll get back to that in a minute in today's present context. So we talk about anatomy, pathology, we talk about physiology, and the last factor that influences our decision in terms of being able to do an awake approach versus an RSI is cooperation. And historically in emergency medicine, this has been our sort of our ticket out. You have somebody who's hypoxemic and uncooperative, or they're agitated because they have substances on board, or whatever the case might be, that you may want to do an awake because of anatomy, pathology, or other physiology, but they are uncooperative to tolerate an awake. And so historically, we've proceeded in doing rapid sequence intubations in these patients. I just want to take you to a very, very simple decision-making algorithm, not to oversimplify it. But again, you have somebody and you're assessing them. I'm not saying that this should be taken lightly. You should formally assess them using what factors you are able to assess at that time in terms of their anatomy. You're going to look at their physiology, and then you're going to make a judgment as to whether there's a difficulty predicted or no difficulty predicted. And if there's no difficulty predicted, then you proceed with a rapid sequence intubation on this patient. However, if difficulty is predicted in a significant manner, then you proceed with an awake approach. And I'm defining an awake approach, which is really about primarily topicalizing the patient and perhaps some anxiolysis, and on rare occasions having to dissociate a patient to facilitate topicalization. At least that's the way I frame the awake approach. And that you often don't have somebody as cooperative as I am here. The one on the left, that's Adam Law, my partner, academic partner in crime, who's intubating me before a shift after doing a beautiful awake topicalization. And the one on the right is me intubating myself. We often don't have somebody that's cooperative and allows us to do this, and this will play into our decision making clearly. And again, I know there's been renewed discussion, and there's been some recent literature about this, how we manage the uncooperative patient. And we've heard, and we know the term DSI, delayed sequence intubation, We've been using a term for years called facilitated cooperation, and we're facilitating whatever procedure is required, whether that's pre-oxygenation, whether that's topicalization, etc. But I'm not of the belief that just using a ketamine-only approach is a truly awake approach. I'm not saying that it's something that should be written off, but I don't really think that we have evidence to support that. And when I employ ketamine as part of my awake sequence, it's on the relatively unusual situation that I can't properly topicalize that patient, and I've been able to topicalize patients with very, very severe disease adequately. But again, there's some other videos that I've talked on the subject, and I'm going to leave that behind for now. So patient outcomes are influenced by the patient's intrinsic anatomy and pathology, their physiology, and ultimately their ability to cooperate. And these factors will influence how we proceed with either an awake versus a rapid sequence intubation. However, there are other factors that influence patient outcomes. And this is where we transition to the dangerous airway. This was a paper that we collaborated on after that meeting in Atlanta that didn't make it to a peer-reviewed journal, but described the concept. And Jared's principle, really goes back to what I was talking about before in terms of the dangerous airway, is that we don't spend enough time optimizing our patients before we intubate them in terms of pre-oxygenation and looking after these other factors. And I'm going to talk about the other contextual things that make this a dangerous airway. So up till now, we've been talking about patient factors, anatomy, pathology, physiology, and cooperation. Well, there's the other stuff, the environment, and that's provider-related, equipment-related, and support-related. If you go back historically, and this is historically meaning using primarily direct laryngoscopy in over 20,000 patients as part of this meta-analysis, in the ED, first pass, at least self-reported success rates of 84%. And while many people say, wow, 84%, that's not so great. If you look at looking after sick patients, whether it's in the critical care environment or otherwise, this metric has stood the test of time. Recognized for this study, this does date back a few years using conventional equipment. In emergency medicine, and actually in pre-hospital setting, this is two examples of very high first pass success rates. So all comers in an emergency department. This is the JAMA study, the driver et al. Study, comparing routine use of a bougie to using a stylated endotracheal tube. And overall, in the bougie group, they had a 98% first pass success rate. And it's a busy emergency department. But the prevalence of airway management isn't greater proportionally than other larger centers, and they were able to achieve this high first pass success rate. In those patients that had predictors of some difficulty, the first pass success rate was 96%. But this wasn't about the bougie, in my view, and I think many people will agree. If you looked at this cohort, this was a cohort that was managed by a very, very well-trained group that had experience with bougie use, that were essentially doing Macintosh video laryngoscopy using a CMAC, and performing a rapid sequence intubation. So it wasn't, in my view, the bougie that made the difference, right? It was this airway bundle that really came along with the training, the adjuncts that were used, and the method of intubation. And they were optimizing airway management and getting high first pass success rates. Now, their first pass success rates without hypoxemia in those with predicted difficulty was 82%. So again, and I'm assuming that, and I'm pretty sure based on the material that they presented, they were managing a lot of very sick patients. So let's get back to, again, our present day context of a COVID-19 protected intubation. And if you look at the details of what's happening here, we've got 3 people in the room. We have 2 emergency physicians and we have a medic. They're using a CMAC VL approach with a bougie ready to be employed. And this is our standard rollout that we use in our department. We don't have a lot of literature around COVID-19 protected intubations around the world, but this is a really nice paper out of Brazil, which we know has been hit hard by this pandemic. And if you looked at the equipment that they were using, at least 50% or close to 50% of the time, they were using direct laryngoscopy. They did have adjunct bougie to be able to employ in this scenario, and they had an 85% first pass success rate. But a fairly high rate of hypoxemia and hypotension, again, I think recognizing that they were managing very, very sick patients. And we know that these patients are going to desaturate very rapidly, and that hemodynamic instability is not uncommon in this scenario. So let's go back, and if we look at Jared's figure here in the paper that I described earlier, are we able to optimize these patients in the same way? So we would use flush rate oxygen in North America, and we can get flows of anywhere between 40 and 60 liters from the wall. And that would be commonly used in the patient with that we have to denitrogenate who has essentially normal lungs. Now, again, there's a fair bit of controversy about what flows are going to generate potential aerosols if they do, but we do know that there is a relationship between flow rates and dispersion distance. So we're limited even in terms of our conventional passive approach. And then again, when you have a breathing patient performing, BiPAP to pre-oxygenate that patient, again, in present-day context, isn't something that a lot of people are comfortable with, even in appropriate PPE and negative pressure rooms and appropriate environments. Again, it's controversial, but you're in no way would you be able to, I think, do this safely if you were trying to assist them with mass ventilation with your own sort of BiPAP device in terms of a BVM outfitted with PEEP, etc. When somebody's got a high respiratory rate, I don't think you can do that safely, and you're going to have asynchronous ventilation and create challenges. And then again, we've been told that the awake intubation is off the shelf, although there is a bit more of a full circle in terms of if you do have somebody that is truly a difficult airway, usually from an anatomic or pathologic point of view, and you have the ability to recruit somebody who's skilled and able to perform this, that it should be done, even in COVID-19 scenarios. But again, doing this for the common reason that I'd been doing it for before in the apnea intolerant patient, this was put to the side, and I know some people have been questioning, is that appropriate? Should we be still considering an awake for the apnea intolerant patient even in today's environment? So it's a real challenge to optimize these patients in the way that we would optimize them previously. The last part is about the environment, is are you optimized? And I've shown this before, and I've talked about the psychological shock index. And the psychological shock index is when heart rate, in other words, your heart rate is greater than your patient's heart rate. So you have a PSI of greater than 1. That affects your ability to perform, and it does impact patient outcomes. And we know that we do need a certain amount of arousal to perform well, and we know that world records are broken during Olympics and world championships because of that elevated positive adrenaline. And so challenge is helpful, but there's a fine line between challenge and it becoming threat, and that threat and then can sometimes create dysfunction, and that dysfunction is not helpful. And so again, if your heart rate's elevated, if your patient's desaturating, and you don't have the ability to monitor waveform capnography as a preemptive signal to hypoxemia, all these things can influence your ability to perform. So Petro and Hicks from Toronto published this lovely paper on Beyond Crisis Resource Management, New Frontiers in Human Factors Training for Acute Care Medicine. And I borrowed this slide numerous times. Halo events are high acuity, low opportunity events. And even though intubation isn't considered that, intubation of a critically ill patient with who's suspected or known COVID-19 is a halo event for most of us. And what we know from the literature is there's two interventions that are helpful in terms of halo events. One is to overlearn, and the second one is System 1 education or System 1 training. So what does overlearning do? Well, when you're doing something that doesn't happen very often, and I'll use the example of a cricothyrotomy, you can't be just good enough. In other words, I just practice this, because you don't do it on a regular basis. You need to overlearn this. You can't be just good. You need to be better than good. And so this is where the overlearning comes in, and you have to create these educational opportunities, whether they be on simple methods of practicing that skill or more complex ones. And what that does is that the skill will still fall off, but when you have to relearn it, the ascent to that better than good status happens more quickly, and then it trails off more slowly, right? So these are the benefits that we see in overlearning. System 1 training is, learn as many and execute as one. So if I think of the 11 steps that are required to do a bougie-assisted cricothyrotomy and start to try to remember those, there's no way I'm going to be able to perform that. I need this psychomotor memory so that I'm doing that. And you can do it quite simply. Again, I've sped this up a little bit, but you can do it just without any equipment, and this will actually improve your skill set. It's not the only thing, and if you see me walking down the hall just doing that, that alone isn't going to be beneficial. But again, it allows me to translate this again to a procedure, as you're seeing here, that was sped up 3 times, but it took less than 30 seconds to perform. And again, we have access in our shop to clinical grade cadavers, and we can train with this, and you get the real tissue physical fidelity, and that finger in that cricothyroid membrane or that cricothyroid membrane space is unforgettable, and you will know what it feels like. So there are ways that you can do System 1 training so that you can learn as many and execute as one. And it's not just you, right, that needs to do that. That's what you need to do from a procedural point of view. This is, one of the perhaps overused videos, but forgive me for doing this on the show again. This is the Ferrari picture. So I wish we all could train to perform as one, as a team. So again, it doesn't matter really whether you execute only alone well at the head of the bed. You have to execute well as a team, obviously. Just the dangerous airway. I've talked about the provider and the environment. What about your equipment? And equipment's taken on a whole new measure these days. So this is, our COVID airway stock kit, and you open it up and you grab your intubation kit dump, whether you choose to use the glide scope or the CMAC. And you have to remember what's in yellow is stuff that you're going to have to bring into the room. And then our airway assistant kit dump. And so we have to pay attention to these details to get the success that we are looking for. So difficult versus dangerous. The last one is really about, are you and your team optimized? And again, this has been something that's been exposed as part of our COVID-19 training. So we do cadaveric training for the procedural skills. Everybody has to go through all the potential outcomes of the algorithm, whether it's a failed intubation, whether it's a can't intubate, can't oxygenate scenario. And then again, what we do is we practice as a team. and we begin outside of the room, and before we go in the room. This is something that I do, and it's it's something that people talk about. But I will do tactical breathing. I'll do 3 cycles of breathing before I go into a resuscitation room. It's the only part of your autonomic nervous system that you have control of, and if you practice it, it will be helpful. And the other thing I do is that, positive self-talk, right? So, I have my mentors in the room. I've got Rich Leviton, who's on one shoulder, and I've got Ian Morris and Adam Law, both the anesthetist mentors of mine, and say if I do what I've trained to do, things are going to go okay, and that's ultimately what usually happens. So this is just a little something that I truly believe, is that expertise isn't about what you do routinely. Being an expert depends on how you manage yourself and your patient when things are out of routine. I love to work in the woods and operate chainsaws and my tractor, etc. But this is my other brother in the woods who's taught me everything I know. And again, taking down a tree is pretty simple, but taking down in a forest is pretty complicated. Remember, complacency breeds incompetence. I want to finish with this. Is back in the day, this is one of my first mentors. This is Pat Crossgary. This is a paper we wrote back in the late 90s, Clinical Decision Making in Emergency Medicine Perspective. And back then, emergency medicine was about prevalence and acuity. It was about, you need to be able to manage whatever came in. And then you need to manage the first 10 minutes, half hour, an hour of everything. And you need to be good at that, and that includes airway management. Now, everything at that point, as I said, was prevalence and acuity. This is at a time when the waiting room was a room. It wasn't this huge space of waiting rooms that we see now that are filled with overcrowded environment. Now emergency medicine is about prevalence, acuity, and complexity, and that complexity comes in because of pervasive issues of overcrowding that influence our ability to deliver care. And in the current state of scenario in terms of COVID-19, it certainly added huge layers of complexity, certainly in the first wave as we're problem solving how we're going to do this differently. But in emergency medicine, again, I think that we are problem solvers, and we're good at doing that. So the difficult versus the dangerous airway, it's about the patient, it's about the environment, and you need to make sure that they're optimized. Just a last message is that slow down, be better than good at what you do, turn crisis into opportunity, and be what the t-shirt says. Emergency physician, I resuscitate. I got a lot of people to thank in the airway world for, again, making my life very rich in terms of what I've learned from these people. So thank you to you all, and thank you to those that are close to me in my local space. Keep well.